Um, Good morning, good afternoon, good evening to everyone who has joined, and welcome to today's webinar, World Stroke Academy webinar. My name is Dr. Ivy and Sebastian, and I will be chairing today's discussion. Recently, the International Journal of Stroke published two very important scientific statements on frailty and stroke and on stroke care in indigenous populations. And today, the World Stroke Academy is pleased to host this dedicated webinar to discuss these landmark publications. Frailty has emerged as a significant and complex factor influencing outcomes in stroke care. And understanding frailty in the context of stroke is become essential as it can affect prognosis, therapeutic decision making, and also the allocation of resources. In addition, addressing stroke among indigenous populations requires a sensitive and comprehensive approach that acknowledges unique cultural, socioeconomic, and healthcare challenges. Indigenous communities across the world experience a very disproportionate burden of stroke due to systemic inequities and challenges and barriers to healthcare. So, with that context, today's session, it aims to provide insight into both the science and also human stories underlying frailty and stroke, and to consider their impact on clinical practice and policy making around the world. We are very privileged to have expert speakers joining us to deepen our understanding on these vital issues. It is my pleasure to introduce our esteemed speakers, Professor Ranta, Dr. Nicholas Evans, and Dr. Margaret Hart. And also we have Dr. Bernadette Jones, each of whom brings a deep expertise to today's topic. Please use, before that, I just want to have a few housekeeping announcements. Please use the Q&A box for any questions during the session. This session is being recorded and the recording will be made available to the attendees. And also, don't forget to complete the evaluation survey at the end to claim your certificate of attendance. So without further ado, I invite our first speaker, Dr. Nicholas Evans. He is a senior clinical lecturer at the University of Cambridge and an honorary consultant in stroke medicine at Addenbrooke's Hospital and director of studies in preclinical medicine, Wilson College, University of Cambridge. Dr. Nicholas, the floor is yours.
Thank you, Ivy, and good evening, everyone from the UK. I will just start sharing my slides, and Ivy, if you can confirm that they are in the usual slideshow, please.
Not yet. Yes, now it is. Yes.
Excellent. So, good evening, everybody. I am just going to move my camera, actually. So it's a pleasure to be here to talk to everybody about the recent scientific statement on frailty and stroke on behalf of all of the group that put it together. I think this is a very sort of apposite time for us to be discussing about frailty and stroke, given that the changes in global demographics. And what I'm going to be talking about today is not only what we said in the scientific statement, but also as well a background to frailty, about some of the mechanisms that's involved in it, and what implication that has for all of us in stroke care. So these are the learning objectives. I'm going to talk about those demographics and also as well really highlight how frailty is separate from from aging, from multimorbidity, and from disability. It is, when we are talking about it, effectively somebody's biological age. So let's put this all in context. The number of strokes across the world is rising. Here in the UK, we have an estimated upward trend in both ischemic and hemorrhagic strokes in the course of the next 10 years. And that's seen then across the globe, as shown by that model there on the right-hand side. But the main reason why the number of strokes is rising, despite then improvements in control of vascular risk factors, is because the global population is aging. And we see that in pretty much every country, that by 2050 globally, there's going to be a doubling of those that are aged over 60 years, up to just over 2 billion, and a rough approximate threefold increase in those that are aged over 80, up to 426 million. And as I said, this is going to affect all countries, and actually quite a lot of the burden and some of the biggest increases are going to be seen in less economically developed countries. This is the trend that we see within the UK, but the UK is not alone. We see shifting sort of aging populations across Europe, across China, and also as well, somewhat anticipating my colleagues who will be speaking later on, also in New Zealand, and that's seen across sort of all of the populations seen in New Zealand. But as much as I've spoken then about somebody's chronological age and the aging population, and obviously we can't do anything about the number of times somebody has been around the sun, what we can potentially do something about is how well somebody ages. So as you'll see here on the screen, here it's sort of an example of two individuals. On the left of the screen is a woman called Harriet Thompson, who in her 90s became the oldest half marathon runner. She's subsequently been overtaken, but I think we can all appreciate that looking at her is behaving very differently in terms of phenotype than from the elder George Bush that we see on the right-hand side, where just from a kind of end of the bed assessment there, we can see that these two individuals physiologically are probably behaving quite differently. And as I often say to the medical students, I think the other thing that's worth us thinking about is that how sort of much older, how much frailer somebody appears when we put them in a hospital gown. And that's why any assessment of frailty needs to consider how the individual has been in the sort of fortnight or so prior to coming into hospital. So what is frailty? Well, frailty is a state of vulnerability. It's characterized then by this loss of physiological reserve. And as a consequence of that, it means that people are far more vulnerable then to stressors. They will tend to get sicker, faster, and for longer. And in terms of outcomes, frailty then, almost regardless of whichever medical condition one looks at, is associated then with increased rates of institutionalization, poorer outcomes, and also as well increased mortality. But as I've already highlighted, although they are linked, the prevalence of frailty is not, frailty is not the same as aging. And we can see here that actually whilst frailty increases in prevalence as people get older, is that by no means is it sort of one and the same. And even individuals into their sort of 80s and 90s, there is still a considerable proportion who do not exhibit then frailty. Frailty, as well as being separate from age, is also separate in terms of construct from disability and also as well from multimorbidity, although of course there is some degree of overlap. So just to sort of highlight then what I've just been sort of discussing is that we can sort of imagine this then using this exemplar by Andy Clegg. For an individual then who is not frail, who is robust, as shown by the green line, they typically start off at a higher level of functioning. They go along and then in response to an illness or an injury, such as a urinary tract infection, there's a drop off in function, but relatively quickly for the robust individual, they are back to their previous baseline. Compare this then to a frailer individual who starts off at a lower level of functioning. They have a more marked drop off in response to the same illness, and that then takes longer then to recover, and very often they don't make a full recovery. So despite being the same illness, being the same trigger, these two individuals are behaving very differently. And this concept then of frailty and its treatment and disease modifying effects is very important because the prevalence of frailty is also high. This is a figure from our recent scientific statement. And as you can see there, it shows on the left those that are starting to develop frailty, those with what's called pre-frailty. And on the right-hand side, the prevalence across continents of those with more sort of frank and overt frailty. But as well as being prevalent in the general population, it's also as well a big issue for stroke. So this is a very nice meta-analysis by Jenny Burton that shows that the prevalence of frailty in stroke is around 1 in 4. But when you then start considering those that have some degree of frailty, those who are pre-frail and on their way to developing frank frailty, the prevalence actually goes up to around 3/4. So this is something that we are seeing a lot of in the clinical context. And it's for that reason there where we felt that there are a lot of knowns, but also a lot of unknowns in how frailty can influence both the disease trajectory and also our treatments in acute stroke. And so the time was apposite then for the scientific statement, and I'm very grateful for all of the co-authors that you see there for their efforts in putting this together. So we identified really across 5 main, very broad areas that I'm going to run through in terms of assessment, acute care, rehabilitation, secondary prevention, and research. So first off, to discuss about how we assess frailty. Well, there's 2 broad schools of thought about how we go about quantifying frailty. There's the concept of cumulative deficit, where essentially, as you see in that quote there, the more that an individual has wrong with them, the frailer they are likely to be. And we can calculate that using a different number of approaches. In particular, the most commonly used is the frailty index, which we'll go through shortly. There is also as well the frailty phenotype, which you see there about the 5 main characteristics as identified by Freud about the characteristics then that somebody is likely to demonstrate as they become frail. And there's a dose-dependent relationship with those. So one of the aspects that we included in the scientific statement was about using the right tool in the right time. So it partly depends on the setting in which one may use it. So the advantage of using a frailty index is it's something that can often be done retrospectively and can be then, as long as your data is fairly robust and you've got sufficient information, granular information within your records, is that you can then calculate it. And the frailty index looks like this, is that essentially that you can then, as long as you've got a robust list of 30 or so more, or 30 or more characteristics across medical conditions, across physiology, across function, then what you would then essentially do is tick off each one of those and divide it by the overall denominator. So in other words, if you've got 15 out of 30, you've got a frailty index of 0.5. And so that allows a a reasonable spread there of information that can be used then in the research setting. However, this approach is really not feasible in a time-pressured hyperacute stroke situation, and that's where a lot of studies and where we use in our centre and a lot of centres across, certainly in the UK, but also internationally, are using the clinical frailty scale as put forth by Keynes Rockwood's group, which is an ordinal scale that looks at somebody's level of functioning and scores their frailty in the 2 weeks before they are admitted to hospital, and is essentially a very, actually, although it relies on information that needs to be gathered from either the individual or their next of kin, it's actually something that very often is actually reasonably quick to do and has been shown to have a good degree of reproducibility between scorers. The important thing that I want to highlight, and was certainly mentioned within our group, is sometimes this confusion between modified Rankin and clinical frailty scales. Is that although that the modified Rankin is a disability scale, clinical frailty is measuring something different. And there's a moderate correlation then seen between MRS and CFS, and it's moderate at best. And this then, when we then look at different models using prognostication, comparing modified Rankin with clinical frailty scale, we tend to see that the CFS then outperforms modified Rankin when it comes to prognostication. But of course, just want to highlight again is that these are measuring different things. And I think there's certainly a case for considering both of these, both in research and within clinical care. And so some of the recommendations we put forward reflect that, is that these are, particularly when it comes to measuring disability and Rankin and CFS, these are distinct but related to some extent entities. And in both settings there, we need to be considering these as important covariables. but also as well is that we need better phenotyping of frailty and its impact across the stroke etiologies. We're going to hear a bit more about how it relates there to acute stroke treatments, but what we don't have is good, robust evidence at the moment about how frailty, how it affects different etiologies and different subtypes of stroke in terms of whether there is a similar effect across these different patterns of stroke. And so a very important area for us to develop. But what about hyperacute care? Well, this sort of has been an emerging area over the course of the last 5 years or so. This is some data from our group that shows that there is, if one simply dichotomizes non-frail and frail individuals, and we look at the outcomes from thrombolysis, that we can see that for non-frail individuals is that there's a significant reduction in their NIHSS in response to the thrombolysis. In contrast, for those individuals who are frail there was no significant reduction. But of course, this idea of dichotomizing frailty is somewhat reductionist. We don't tend to see this, kind of clearly in clinical practice. Frailty represents a spectrum. And when we then looked at it from using that spectrum of CFF points, we essentially found that for each additional 1 point in the clinical frailty scale was associated then with a reduction in an NIHSS improvement of 1 point then following thrombolysis. Similar things have been seen in frailty and thrombectomy. Here are some of the sort of early papers that point that out, but a sort of fairly consistent effect that we are seeing in terms of an attenuated benefit or an attenuation in the benefit following thrombectomy. It's important to highlight that there seems to be an attenuation rather than an elimination of the benefit, because again, this is where looking at frailty as a spectrum is going to be important, because what about those that have a moderate degree of frailty? What we're typically tending to see is that there is still some benefit, although it is reduced compared to those that do not have frailty. This is a meta-analysis and a systematic review and meta-analysis done by one of the students within our group, which is currently under review, which shows that pretty much across these studies, the mortality following thrombectomy, following stroke and following thrombectomy, there's a fairly consistent increase in the mortality at various time periods following thrombectomy. But actually what we're not seeing is a significant impact in terms of the overall outcomes, in terms of their level of function and disability, and also no impact on systematic intracerebral hemorrhage following thrombectomy. Now, part of the field has moved on to considering about mechanisms underlying why frailty may have an impact. And what we have some work done by Esme Dole has shown that frailty seems to frailty seems to decrease the amount of penumbra at the time of presentation. And this seems to be consistent even after adjustment for age, for collateral score, and from time from onset to imaging. And what we seem to see from that is that this seems to be mediated by an inflammatory process. So we could see that frailty was associated with CRP levels, but also the CRP levels were linked then to the inversely related then to salvageable penumbra. Frailty is also as well, we found associated with the degree of inflammation within atherosclerosis. So on the left is a PET image of somebody, an FDG PET image looking at inflammation within atherosclerosis. And again, we found that these measures seem to be associated reasonably well then with somebody's overall frailty scale, relating to that sort of concept of inflammaging. But what about intracerebral hemorrhage? Well, we also see as well that there's a relationship there. And with each 0.1 increase in the frailty index was associated then with sort of poor outcomes, even after adjustment for the sort of conventional risk factors that one considers an intracerebral hemorrhage. So in terms of recommendations from this, we've said that actually what we need is a lot more work, sort of looking at mechanistic work, but we need to think about sort of larger prospective studies. There's quite a degree of heterogeneity when it comes to looking at in the meta-analysis that we did. And what we need to do is sort of large prospective studies that look at the best way of measuring frailties in a different number of settings. And we need to think about that moving beyond a dichotomized approach to one with a much more nuanced sort of spectrum. So these borderline cases are easier then to consider. In terms of rehabilitation, well, actually, there's been relatively less that's been done around frailty about rehabilitation, but that is rapidly changing. It is very much an emerging area, and every week we are seeing more papers. Again, going back to Jenny Burton's meta-analysis is that, and systematic review, is that we see that frailty, again, in the post-stroke setting, in terms of the rehabilitation setting, seems to have a profound number of effects across a range of different criteria in terms of somebody's recovery, including their discharge destination. And in terms of then looking at poorer outcomes, again, this is just an example about the profound effect there that frailty can have across a range of different factors that are important in somebody's recovery after stroke. But although there's an emerging area, there's more work being done the whole time, is that compared to considering the complexity of post-stroke recovery, is there's actually still a paucity of research in terms of the impact of frailty on somebody's recovery. In particular, work looking at how frailty relates with polypharmacy, aphasia recovery, apathy, fatigue. These are all ones, particularly when we think about the phenotype that we discussed earlier on, that is likely to have an impact, and we need to have a better understanding so that we can start to think, is there a role for tailoring rehabilitation strategies for those with concurrent frailty? And indeed, cardiology have been doing this for a little while now, looking at cardiac rehab in individuals after heart attack and adjusting it then for those who are also have frailty. And finally, as well, in terms of the life after stroke aspect, what impact does frailty have in terms of sort of setting goals, in terms of rehabilitation goals, but also as well about advanced care planning, and particularly a role in sort of looking towards sort of those individuals who are at a higher risk of approaching end of life and how we approach that planning and being able to better predict that. I want to then just move on to about an area that where we found there was very little evidence was around frailty and secondary prevention. And indeed, a lot of the work that we mention in the scientific statement is based off then what's been done within the primary prevention setting or broadly within cardiovascular risk reduction. And the principle lies is that we see here that for cardiovascular outcomes for those older individuals is that if we then consider then their degree of frailty, that we see that there's increased risk of cardiovascular outcomes for those individuals with higher blood pressure who are either robust without frailty or those with mild frailty. But when we consider those that have moderate or severe frailty, is that actually the control of blood pressure doesn't really seem to then have an impact then on cardiovascular outcomes. So there, even though we're just looking at the broad age groups, is they're behaving very differently according to their frailty status. And this is similar seen by some work by Ollie Todd and his colleagues that found that when you consider then sort of mortality and you look at whether tighter blood pressure control below 140 versus above 140 is associated then with all-cause mortality, for those that are non-frail, then tighter blood pressure then seems to reduce the risk of that. But in contrast, for those that are frail, there wasn't then an impact in terms of benefit in terms of all-cause mortality outcomes. So what we need to be thinking of within the field is how this relates to our stroke-specific secondary prevention strategies, which is an area where at the moment there is a marked paucity of data. One that I often use as an exemplar just in closing is around carotid endarterectomy. This work done by the group in Oxford shows that there's a sort of the perioperative risk of the perioperative risks associated with carotid endarterectomy by age. The effect of age is modest, but even though that actually we are seeing only a modest effect from age in these cohorts, when one then considers frailty, this is when it becomes much more apparent there that there is some difference in how these individuals are behaving, and that frailty was independently associated in a large cohort of individuals undergoing carotid revascularization with periprocedural stroke and also in hospital mortality. So our recommendations from that are we need robust studies, in particular RCTs, that consider frailty there as a modulating factor in our secondary prevention strategies. And in order to do that, we are going to need the expertise across stroke clinicians, neurologists, and geriatric medicine researchers to incorporate these elements of nuance. So just in closing, what are the future directions for the field? Well, we're already starting to move beyond then just looking at these associations, but thinking about what the mechanisms are that may potentially be able to be something that we can target and treat. We need to think about the secondary prevention for these individuals, as we've already mentioned, either to avoid over-treatment and polypharmacy, but also as well ensuring that we're not being nihilistic and missing out treating people that would benefit from it. And finally, as well, also thinking about how it affects the group then that are undergoing rehabilitation and the impact that frailty can have on their illness trajectory, the disease trajectory after stroke, and an impact on their rehabilitation goals. So in summary, frailty is common in stroke, and as we've seen, potentially some degree of frailty up to 3/4 of individual presenting with stroke, and it has profound disease and treatment modifying effects across the entire stroke, sort of all elements of stroke care. There is limited but growing research into this area, in particular because a lot of these individuals then, because of frailty and the kind of proxies then of frailty, in particular around age and multimorbidity, and have very often been excluded then from research studies. So it means that although we are seeing a lot of these groups in clinical practice, a lot of our evidence has not arisen from groups who have frailty. So we're extrapolating then. And finally, that we need that research at both population and mechanistic levels. So with that, thank you very much again for the invitation to come and speak. I want to thank my co-authors again and for your attention, and I welcome any questions you may have.
Thank you so much, Dr. Evans, on highlighting so comprehensively the impact of frailty across the entire spectrum of stroke, and how very important it is to consider frailty as a factor in stroke care, which can influence patient outcomes. At this point, I would like to remind the attendees that they can put in their questions into the Q&A box. The chat box is disabled, so please put in your questions into the Q&A. We don't have any questions so far, but I do have one question for you, Dr. Evans, before we move on to the next section. So is frailty more of a one-way trajectory that can be slowed, or is it reversible? I'm very intrigued to know that.
So I think that's a really interesting question because, as well as being able to use it to stratify people, prognosticate, and to think about how different treatments are affected, take it back a step. It would be much better to be able to prevent frailty. So this is where I think a lot of primary care work is very important to try and arrest that frailty disease trajectory, identifying those with a degree of pre-frailty for sort of targeted intervention. But there is actually a good amount of evidence that suggests that frailty to some extent is dynamic and is potentially reversible as well. So, we should be almost viewing every contact in a healthcare setting as an opportunity then to identify people that are on a frailty trajectory so that we can do something in order to try and reverse it. Obviously, that reversal and that sort of either slowing or reversal of frailty is something that's much easier to do when they're at an earlier point in that trajectory. By the time it becomes then very severe, it becomes much more challenging. Not impossible, but more challenging. So yes, we shouldn't be nihilistic or consider it futile. There are lots of potential ways that we can intervene. Frailty, particularly if we're thinking about it with sarcopenia and that loss of muscle mass, what can we be doing to maintain that or build that up again, particularly after an acute illness, for example?
Mm-hmm. Mm-hmm. Thank you so much, Dr. Evans. Very interesting. We'll come back for more of this, but I think we should move on to the next
I will
set of our
stop sharing.
speakers. Yes, thank you. So for our next talk, we have Professor Anna Ranta. She is the head of the Department of Medicine and consultant neurologist at the University of Otago, Wellington. She's also the medical director of the New Zealand Stroke Foundation and serves in the board of directors of the World Stroke Organization. She will be sharing her talk with Dr. Margaret Hart. She is an Indigenous scholar and a PhD student at the School of Medical Rehabilitation, University of Manitoba, Winnipeg, Canada. Over to you, Dr. Anna and Dr. Margaret. Thank you.
Can you hear me?
Yes.
Yeah,
And we
okay,
can
thank
see
you.
your slides as well.
Great. Tēnā koutou katoa, haere mai, he waka ika noa ti he Māori ora, e te whara o te iwi te nakwe, e te whenua tapu o te maria te nakwe, e rere haere ana ngā mihi ngā te toa ki ati awa te mana whenua o tēnei rohe. E ngā mate e o ki haere atsura, koutou kua hui hui mai ngā kanohi ora ora a tāwe tēnā hoki koutou. No tia mana o ka tupuna, no tia mana aho, ko elba te awa, ko koko te monga, ko Lufthansa te waka, ko ana Ranta toko ingoa. Good morning, everyone, from Aotearoa, New Zealand. I just gave you an Indigenous Māori greeting, recognizing the traditional custodians of the land we meet on today, where I am here. Margaret is here as well, which is lovely, and recognizing our ancestors and paying our respects to our elders. And then I told you a little bit about myself. I'm originally from Germany. My river is the Elbe River in Hamburg. My coco's my mountain that I see in the morning when I wake up, and the waka, the canoe with which I reached New Zealand, was Lufthansa airline. So this is just a traditional way of starting presentations in Aotearoa, New Zealand. And thank you very much for attending today and listening to our talk around the scientific statement, which I'll present. I'll start the presentation. And 1 second. There we go. Neither of the speakers have any relevant disclosures. The only disclosure I just want to mention is that I myself am not Indigenous, which is relevant to this presentation. As you will see throughout the presentation, we're wanting to move more and more towards by Indigenous, for Indigenous, and so I need to be a little bit of something, a thing that's moving into the past. But fortunately, I've got Margaret Hart here, who will be doing the second half of the presentation, and also Bernadette Jones, who served as our kaumatua on our panel, which is the Indigenous Māori word for elder. And throughout Indigenous communities across the globe, we've identified that elders are highly respected for their wisdom and contributions. Bernadette is also an Indigenous researcher and very experienced nurse by background. She's provided amazing insight. She'll be joining us for the Q&A. So why did we want to do the statement? So stroke in Indigenous peoples is a topic, a really important topic, because when you look at the epidemiology, Indigenous peoples generally experience higher degree of stroke risk factors, higher incidence of stroke and stroke presentations at a younger age, higher stroke mortality, and reduced access to high quality stroke care. Now, it's interesting, when we did the statement, and some of our panel members reported this as well, there are some, not many, but there are a couple Indigenous populations who have reduced stroke risk, but this seems to be linked to maintaining traditional practices and lifestyles, and this is increasingly under threat due to loss of land, culture, traditional practices. An example of this are the blue zones, which you've maybe heard of. We did have an Ainu Japanese member of our panel, and she reported to us and provided some references that the Western interest in the healthy lifestyles of Ainu Japanese Indigenous peoples has really damaged that aspect of their culture, and we are seeing increasing evidence of earlier stroke risk and other health problems. And there's also an issue of biopiracy, where we go in and steal, so to speak, traditional knowledge and make use of it for our own purposes and leave mayhem in our wake. So these are some of the issues that prompted us to be very excited when we were invited to do an Indigenous statement. And the purpose of the statement is to provide some guidance on how to offer stroke care in Indigenous peoples, provide strategies to eliminate current inequities, and guide research approaches and priorities. This is the panel. I won't go through everyone. Everyone's contributed immensely to this effort. It's very much a team effort. I just want to highlight on the far side that the majority of the panel did self-identify as Indigenous, which was very important to all of us. And I also, again, want to recognize Bernadette for inclusion as a kaumatua, and also Tereku Stewart, who's a Māori person with lived experience. This is a group of one of our meetings, and just made a lot of friends in the process. So the way we've structured the statement was a little tricky, because Indigenous research is done quite differently and knowledge systems are quite different. And so we try to interweave approaches. And we did a traditional systematic literature search. We did not include epidemiology. There's a lot of data, I should say, the majority of the data out there on Indigenous on stroke in Indigenous is epidemiological. And basically what happens is we describe the problem over and over again, and we know there's a problem. So we wanted to move beyond that and start looking towards solutions. We wanted to look at a little bit more, why are there differences, and then what can we do about it? So we focused on articles looking at access and barriers, and then solutions. And we created tables that display this evidence, all the relevant papers in the manuscript. And I recommend you have a look at that, some really wonderful resources. But what we primarily focused on is then theming the messages across all papers into these 5 cross-cutting themes. And you see the woven mat on the right that showcases this interwoven approach, which we think is perhaps a slightly novel way of going about this, but an effort to integrate knowledge systems. And with that, I will pass on to Margaret, who will cover these themes.
Oh, thank you so much, Anna. First of all, kinanaskumit nawag aginaw, nawagumaganak. I first want to thank Anna for working in good ways around stroke care prevention and intervention. I also want to acknowledge Elder Bernadette in the room. I absolutely appreciate the wisdom that you brought forth. And so the first part is the historical context versus biomedical drivers of disease. One thing we noticed, nearly all of the reviewed literature from across the globe identified stroke-related health inequities experienced by Indigenous people that relate to socioeconomic, cultural, and environmental consequences attributed to colonization, marginalization, systemic racism, and power hierarchies. And so we were looking at some of the intergenerational trauma that was occurring, and there is and continues to be a profound loss of trust with Indigenous peoples and communities. There are parallels around the world around settler governmental policies of assimilation, forbidding the use of language, cultural customs, knowledge systems, and healing practices, resulting in power imbalances and loss of self-determination. So really with this, this first weaving, if you will, the call to action is to have and work towards a collected responsibility to rebuild the eroded trust. Next, please. So the second was the holistic strength-based trauma, strength-based approaches to health, well-being, and recovery. And so we looked at the importance of non-physical aspects. So we're looking at individual versus community and family focus. So a lack of illness versus promotion. So we did take a look at, when we were talking about holistic strength-based approaches to health and well-being, we're looking at the physical, mental, emotional, and spiritual and community health and well-being. And so many Indigenous people view health as the presence of well-being rather than the absence of disease. And this was actually very much evident in all of the articles and case studies that we reviewed, that we needed to bring in more Indigenous-based practices within community, for example, ceremonies, traditional medicines, etc. So we're looking at tailored approaches to culturally specific and integration of Indigenous and Western ways of knowing. We really like the balance. We're seeking basically what I would say in my language is wakutwin, and this is the idea of relationality and relational accountability, walking alongside communities and being able to integrate both knowledge systems as evident and basically just as important as the Western's way of looking at stroke. Next. Did you want to add anything, Anna?
No, it's all good. Excellent.
Okay, and so this is a really big piece for me, the communication and cultural safety. When we took a look at the cultural safety piece, the first thing we asked is, well, who determines the person's safety? Is it the basically the Western institution, or is it the communities? And so we decided to work towards cultural humility and cultural safer care. And so safer care is positioning us that we are working towards a trajectory. And so this very important piece is improving communication between stroke healthcare providers and Indigenous communities and families. And so the major barriers that we are noticing is educational materials are often monocultural in their imagery, for example, that you see here, including people in the pictures and their environments and the activities they display. So if you take a look at this, you see the woman washing the dishes. She's got an apron. If this was actually, if you were consulting with Indigenous people, more than likely the imagery will actually represent the land and the practices that we bring forth in some of the work that we do. And so when developing culturally safer tools, it is imperative that we involve Indigenous peoples with lived experience. This is the key here. Lived experience to inform the design and to ensure that we're not stigmatizing imagery. And so we're avoiding that piece. So the land is a great image, and the relationships that we gain in the process is how we relate to health and well-being. I don't know if you want to add anything here as well, Anna, but if not, we'll continue.
Go ahead.
And so Indigenous knowledge systems, decolonizing methodologies. And so we're looking at ways, the different ways that Indigenous people globally look at health and well-being. And so a part of the key recommendations for this is that we have Indigenous leadership and researchers leading some of the research within First Nation communities. This is ways to build trust and relationships and reciprocity, because in this case, it is crucial to prioritize culturally safer practices. And I'll give you just some examples. Like we talked about safer care, but when we talk about like stroke care, an example that I've recently encountered was this idea of homelessness and stroke. And the critique that we got from the community right away was like, most Indigenous people around the world are not homeless, they're houseless. And so it removes that idea, like they are home in their communities and they're right. And so just very specific critiques in the way that we're using some of the language. But the true transformation that will occur is when Indigenous health and research leaderships are fully entrusted so that Indigenous people themselves can do the work. The importance of self-determination cannot be overstated here. And also the reporting guidelines. And we actually use Consider. It was a framework that guided our scientific statement paper. And it was from an Indigenous worldview and methodology. Anything you want to add here as well? I actually want to talk a little bit about the need to develop a workforce for Indigenous scholars and clinicians within stroke care and prevention. And so here's what we're also finding. The literature is also stating that Indigenous scholars are not present in stroke right now. And so we actually need to be creating a pathway around how Indigenous scholars can contribute to the stroke discourse around Indigenous peoples and communities. And so our challenge, of course, is being able to apply for grants, because in most cases, our methodologies are coming from either communities or land-based. And so we found in most of the case studies, there are qualitative research practices that really ground storytelling and lived experience. We also recognize that lived experience is not considered robust research, if you will. We wanted to work towards accepting and honoring lived experience as a part of the trajectory moving forward. And so this is kind of the promotion of how we work within conferences as well. And so publication and conferences, I hope will move towards accepting some of these presentations. And so we see a couple of that happening worldwide. And so we see that in Australia, New Zealand. We don't actually see a lot of that either in US and Canada. Australia and New Zealand are really leading the way in stroke care. Did you want to add anything here, Anna?
I just might add that it's kind of a bit of a vicious cycle. So in my role as head of department, we, for example, when it comes to promotion, we have criteria for promotion in the university setting. And it's a really great example that I've become aware of through doing this work of systemic racism, really, that persists because our guidelines are entirely Western based, so we prioritize randomized controlled trials, as Margaret already said. So that's what gets us grants, that's what gets us publication, and that's what's prioritized for conferences. So if you're an Indigenous researcher who is true to Indigenous knowledge systems and uses those methodologies, you're almost immediately excluded from all of these situations, which is why having the opportunity to do the statement and present this here and present it at a conference is so exceptional and wonderful. But if you don't hold those opportunities, you then don't have publication on your promotion, and then you're just already on the back foot. So it's just very much a cycle, and people can get pretty easily discouraged if we don't create opportunities for people to show their output and impact in other ways. And actually, if it comes from my experience working with Indigenous researchers, the impact is much greater if you put the publications into the local newspaper or return the information to the community, which really doesn't get onto your CV very effectively unless your organization prioritizes these kinds of impacts. And so even looking at what health research impact means can be quite critical, because if you don't measure impact in the way that is actually impactful for the community you're trying to improve, but only serves Western paradigms, then you are not going to break that cycle. So I just thought I'd expand on that a little bit from perspective as a head of department. Thank you for the opportunity, Margaret.
I actually wanted you to cover this piece, if you didn't mind, Anna.
This piece here?
Yes.
Sure. So this is actually a bit of a continuation of what I was just talking about. So one of the themes that we came across in the literature review that we did was the differences, not just in research methodology, but a really key difference is when we look at Western science, we always talk about generalizability, and we rate certain methodologies like RCTs or experimentation very highly because we know that in our setting they produce really good results, but they have high great evidence, there's great study power, and then we can generalize it to lots of other populations. But this is very much founded in a biomedical model of health, and it doesn't prioritize social mechanisms of disease, which we're becoming much more aware of in general, not just Indigenous, but health inequities, housing, education, wealth, all these things, they're not necessarily related to a biomedical pathophysiological mechanism, and they may really need to assessed in a different way. And when you're talking about RCTs, the other problem is you need to get people to consent to be in an RCT. And we have this problem that a lot of minority populations, including Indigenous, including women actually, are more reluctant to be part of RCTs, randomized controlled trials, and don't consent. And so you have actually reduced generalizability because you're just testing a subset of the population. And so we have underrepresentation of Indigenous peoples in these results, and often then as a result, these results feel completely irrelevant to local communities, especially when you add that the strong connection to community and land and culture, then actually generalizability doesn't really work because yes, we're all humans, but if culture is really important, then one intervention may simply not be relevant and may not work. And this then results in reduced uptake. And then we go and say, well, they're not doing what we tell them to do, so they must just not understand how great we are. and this is very much sort of from my non-Indigenous perspective, but this is what I see in communities. It's like, well, why would we do that? Like, that doesn't make any sense. That doesn't fit into our community. We weren't part of the research. We weren't even considered as part of this research, and we are just expected to consider it. And there's this huge historical distrust that contributes to that, because let's not forget that a lot of minorities, and especially Indigenous peoples, have been experimented on for the benefit of Westerners. So in favor of, promoting actually uptake, we need to include local involvement. And then that creates this tension between having small studies that are locally relevant, that are culturally relevant, that are co-designed, that just don't meet the bar for publication in big impact factor journals. And then that comes back to the previous point I was making, that we then don't progress that knowledge base, and studies don't even get out there. So some solutions to that are to, continue RCTs. We know that is a good evidence. And as Margaret said earlier, we want to interweave these knowledge systems, but then build into the grant application some opportunity for local adaptations in communities that aren't quite aligned with the paradigms that we use for our RCTs. It's just one example of how we could do this. And I think probably more importantly, as people who sit on grant committees and editorial boards and conference organizing committees, to allow to increasingly think about some of these issues and make space for other topics. I mean, I've heard just in Barcelona, heard somebody say, we focus on a really high quality program, with the implication that we've excluded people from the program who we think isn't good data for whatever reason. And that doesn't sit very well, because it's this kind of progresses this idea that we have this preconceived notion that Western science is better. Are you happy to go back to that, Margaret, or did you want me to continue?
You can continue. Thank you.
Okay. So this is just our last slide, and this is a summary of the recommendations. So we presented the 5 themes, and the recommendations are these 11 recommendations, and they're grouped into a number of topics and aligning again with the themes. But to run through them briefly, and they're immediately born out of those themes, is we want to start by acknowledging the current inequities and focus on equitable access. So if we can achieve that, we will have made a big inroads into the problem. We want to encourage a more holistic view of stroke care, which aligns more with Indigenous worldviews. We want to incorporate Indigenous practices. So these are tools to achieve higher equity. And we want to really people services to consider implementing systematic cultural safety training that Margaret talked about, because there's a difference between cultural competence, which is understanding of the culture, other cultures you're working with, and cultural safety and humility, which is more of a self-reflective process of really also considering our own cultural background and our unconscious bias when we're interacting with people, Indigenous people. And we want to improve cross-cultural communication, which really starts with that cultural safety and cultural humility. But it's that's then the next step, to really embrace and learn from each other, to have better communications, to achieve better uptake, to build trust. And underlying all of that, again, as Margaret mentioned, is the critical piece of developing the Indigenous workforce, so that we can drive this forward and really absolutely empower self-determination. We need to stop doing the work on behalf, and this is why I'm sort of apologetic about even speaking here. We're in a transition period. We're still working on developing Indigenous workforce, but people like me need to step back, and shouldn't be our publication. They shouldn't be our work, because we want to make that Indigenous voice absolutely central, because they'll be better equipped to talk to it, and then we empower the development. A couple other things is around data and data collection, which we didn't talk about much before. I think Margaret mentioned it early on around disaggregated data. So some countries do not allow disaggregated Indigenous data, where it's not allowed to capture Indigenous incidents, for example, by ethnicity for various reasons, either because the cultures are not acknowledged or because there's actually this belief that that creates racism. But the strong voice of the Indigenous community is they want disaggregated data so we can clearly identify the problems, visualize them, make people aware, and then track them over time. But with that comes also a responsibility of data sovereignty. We need to acknowledge that the data that is collected within Indigenous communities is their data, and it does not belong to the researcher. And so this is a very important concept that was highlighted throughout our work and the various research pieces we reviewed. So this is something we want. So if you don't know what data sovereignty is, I don't have time to talk about it, but if you work with Indigenous people, you must understand that concept. And then we want to prioritize Indigenous research funding and making, like this topic again that I talked about, just creating a space for this work and funding it, publishing it, promoting it at conferences, and ensuring that whenever possible, it's Indigenous-led and involves the community. Again, a key point that Margaret touched on. And then finally, again, Margaret also talked about the consider statement. So it's not just enough to fund and publish. We also want to ensure the rigor around publishing. So when we publish Indigenous pieces of work, we want to adhere to an Indigenous publication guideline, just like we do with RCTs or observational studies. And that's a really great tool for especially non-Indigenous researchers working in that space to have a checklist to see and educate yourself as to what it is that needs to be done to create a safe environment and promote this type of work. And that's where we finish, and we have some time for questions.
Thank you, Professor Anna and Margaret, for this excellent talk on stroke and Indigenous populations. And you've highlighted some very unique challenges and issues that deserve far more attention than is being given. We don't have any questions in the chat box, but I would like to direct a question to our elder in the panel, Dr. Bernadette Jones. She's also a research associate, professor and senior research fellow in the Department of Medicine, University of Otago, New Zealand. And Dr. Jones, would you be able to expand a bit more on the concept of health literacy that was discussed earlier?
Oh, kia ora, Ivy. Thank you for that. I think the health literacy is really quite a core concept and very important for our Indigenous people because it's very closely related to the use of language. And for health professionals in general, they see health literacy as just educating the patient. And it's not about educating the patient in Western ways. It's not about using biomedical terms, and it's more about understanding, as Margaret said, the perspective of the Indigenous people, to be able to talk and understand what's important to them in ways that are important, and in an approach that engenders trust. And first of all, that trusted relationship is important because there's been so much intergenerational trauma for Indigenous people that it's passed on and it's still impacting on our Indigenous populations now. So there's not a trust of our Western health systems. So it's very important to build that trust and then to understand some of the language that our Indigenous people use. For Māori, we always suggest learning key terms, just, basic terms, so that it shows that there's some level of cultural competency there from the health professional, and having a really good understanding of health literacy approaches. What does the person know? Build on what the person knows. Don't try and tell too much information all at once, and relate it to concepts, Indigenous concepts that are meaningful to them. And I've seen some really good, effective ways of using health literacy under the umbrella of cultural safety. Kia ora.
Right. Thank you so much. I think I've learned so much just by listening to all of you talk about this. It's been such a extremely interesting and learning experience for me. I have a question for Dr. Evans here. So I am from India. So most studies from LMICs, we have younger ages of stroke and high stroke burden, large gaps in surveillance and data collection, and it becomes difficult to estimate the true impact of frailty on stroke outcomes in these populations. Now, without so much of robust data. What do you think? How can health systems and LMICs effectively address frailty among people with stroke? And what strategies can we use to support better this vulnerable population in our countries?
Thank you. So that's, I think, a really interesting question, and one that, obviously the impact of frailty in a number of different sort of cultural settings varies then quite hugely in terms of the effects on things like, for example, institutionalization after an acute illness, because we see that that varies very much from setting to setting. In terms of then a lot of sort of large sort of data sets then are generated from primary care data sets, but exactly as you've highlighted, that's dependent on then the infrastructure being set up and also frailty being incorporated into those data sets. So I think then the next bit is to think about, well, what is the most user friendly and operationalization the best form of frailty measurement then in that context? Actually, probably something fairly straightforward like the clinical frailty scale that can be employed at, sort of without much extra time being required then during any sort of kind of clinical encounter. The frailty index takes a lot of time. The CFS that we showed earlier on can actually be done quite quickly. Some will say sort of to do it well, probably a couple of minutes or so. And so I think that is a much more sort of user-friendly way of starting to build it up. So from the studies perspective, those I think would be much more sort of able to sort of use prospectively. And then it's thinking then if one has a larger, bigger data set, well, that's how do we start incorporating frailty index into that. But remember, a lot of databases now are international, and therefore it's making sure that we are then incorporating those into that so that actually people from across the globe can access those resources to make these conclusions, even if they're actually being hosted then sort of elsewhere.
Yes, thank you, Dr. Evans. And here, Dr. Jones has also asked a question back to you. She says, I wondered if there is a relationship between dementia and frailty.
So that's a really good one, and the likelihood is yes. The question in part, which we're still trying to kind of evolve, is, well, sort of what components then of dementia. So some of the work that we are doing, we know there's this concept of a frail brain. So certain characteristics of the brain, small vessel disease, atrophy, previous silent sort of stroke, silent infarcts, there are three main characteristics then which go along with this concept that the brain is less likely to withstand an insult, be it from an illness, be it an infection, be it stroke or anything. But all of those characteristics also as well affect cognitive impairment. So certainly from a vascular perspective, yes, we've seen that the inflammation that's going on within people's blood vessels seems to be associated with inflammation in the brain, seems to prime the brain then for injury. And as part of that priming, it does have the effect then, particularly from a vascular component of dementia. The area then around sort of Alzheimer's, I think, is perhaps slightly less in terms of the run up to Alzheimer's is slightly less researched. But then in terms of the disease trajectory, then when somebody develops Alzheimer's, yes, again, we see that frailty then does modulate that. But again, it's drilling down into that phenotype of the different patterns of dementia.
Right, thank you. If I may ask a question to Professor Anna and to the whole team from New Zealand, you spoke about the importance of involving people with lived experience. I was wondering if you could give some specific examples or of strategies or initiatives that you have seen work really well with the indigenous populations to improve stroke care. Especially since you also mentioned that, self-identification and data sovereignty, these are sensitive issues that we are kind of those are challenges that we are struggling with in this population.
I can answer, but I'm sure that both Margaret and Bernadette can answer as well. So I'd like to give you the first opportunity to answer that if you'd like. Margaret, do you, or Bernadette, either one?
Kia ora. I think one of the things that stood out for me in a current stroke project that we're doing was listening to somebody who talked about their experience of stroke and how doctors spoke to them about what had happened after a stroke. And this person was told that basically part of your brain is dead. And this came as a real shock to the Māori stroke survivor. And because in Māori culture, the head is sacred or tapu, and to be told that the most sacred part, the part that you value the most, is dead, had a profound effect on him. And he found it extremely rude and couldn't take in anything else that was told to him. And so he never spoke to health professionals after that. His whānau or family came to visit and he could speak and articulate to them, but he would never speak to health professionals because there was no trust left. So we found it extremely valuable having people with this lived experience to be able to tell us some of these perspectives for them of their experience. Margaret, did you have any you wanted to share?
Oh, absolutely. So part of my work is working with multiple First Nation communities, and these are experiences that you're not going to have within the institution. These are the experiences, the lived experiences that are coming through with the institution, with the practice, but also the care they are receiving. The educational piece is what is also a key aspect. The literature was profoundly evident and obvious when we talked about the communication and the culturally secure care that was stressed throughout the whole the case studies. That communication is a barrier, and I could speak for myself. My mom passed last year from a stroke, and the education that we received from the hospital was none. We did not get any materials or resources, the ways that we would navigate even the care or rehabilitation that needs to occur. And this was also stated in all the conversations in the North. And we noticed that all stroke care is you could find that within urban centers. You can find that in rural areas. And so within my context, we're 7 hours away from the closest stroke facility. And so to even navigate that facility is even concerning in that case. None of the stroke neurologists in our area are currently trained to work with Indigenous local people. They don't, I'm not even sure if they are aware of the First Nations within our region. And so it is really a call to action to start training stroke neurologists and clinicians around local context. And I just want to stress that it's a very, very important part of our work moving forward. I'm in education. I've been in Indigenous education for 30 years, and I continue to work in that area within medical education, and also bringing that lived experience and voice is key to that understanding. Anna?
I might just add a couple solutions that we're just in the working on this. Like this is still an evolving field, and we have a bunch of examples in the paper. But I just thought I'd mention a study that Bernadette and I are PIs on at the moment. We don't have the results yet, but we partnered with communities, and Bernadette's story comes from one of our people with lived experience of stroke. And we co-designed a patient booklet to be used in the inpatient ward that had a health literacy review to make sure it's fully understandable and culturally relevant. The community added some local photographs of the land, of the nature around that was meaningful to them. And we had this like space. There's a lot of education. They wanted a lot of education about what a stroke is, what it means. And so we created this resource that is supposed to be filled in by doctors. And we also integrated traditional healing practices on the ward that both white and Maori people can access if they would like. And we have done an awareness campaign in another district where everyone told us you need to use the actors to do the videos because there's not Indigenous or non-Indigenous, but like lived experience struggle to say the messages we want to say. And so we resisted this a little bit. And the whānau was like the community really didn't want actors, and they said, no, we're doing it. And we worked with a local movie maker who had an understanding of the community, and together they produced these wonderful fast video clips, and they weren't what we thought they should say, but they said what they thought they should say, and they've just gone viral in their communities, and they're like local celebrities now, and the stroke awareness has really gone up. So I think it's a long road, and you have to get through a lot of storytelling, and a lot of bad experiences that people have had to get through that and look for some positives and look for some hope. But you can get there if you put the time into it, and it just takes longer than other research. It's not analytical; it's a bit circular, and it's very building trust. And I think even if we don't improve outcomes with this, we have improved engagement with the community. We've developed research capability amongst the community to participate in future research, and we've done capacity and capability building of local rural clinicians into new Indigenous researchers. So I think that's I'm not saying that we got it all right and we're still learning, but I think it's an example of how I would have never gone about it like this if I didn't have Bernadette to guide me along the way. So it's just a partnership that's hopefully training the next generation of participatory action, community-led and locally Indigenous-led research.
Thank you so much. This is truly fascinating, and I'm, such remarkable and unique insights about the Indigenous population. And really, you've nailed it, Anna, by saying that, it's more about building trust with the community, and that's probably the first step for taking it forward. Um, we are past time, but if there's time, I just want to put one question for kind of the whole panel. Given that there is a higher prevalence and earlier onset of frailty amongst Indigenous stroke survivors, how does that impact the design and delivery of culturally appropriate stroke care, and what strategies can be developed to integrate both community-led approaches as well as biomedical approaches to improve outcomes for this vulnerable group? And I think it's open to the entire panel. We could just have maybe 5 minutes on this.
Almost who wants to go
Kia ora.
first?
Do you want to go, Nick?
No, please.
Okay. I was just thinking of this current study that we're doing where we asked our Maori with lived experience of stroke what they thought we needed to do. And I think that one of the things they said was they need a better understanding within the community of recognition of early signs of stroke, recognition of how to prevent stroke. And I think that their approach was developing, as Anna mentioned, their own videos, their own sort of stroke awareness campaign, and being able to deliver it in ways and in places within their community that was meaningful to them. So I think if you incorporated aspects of frailty and how that impacted alongside stroke as well, that they'd be very open to that. So it's about asking, how do they share messages? Where's the best place to go? Is it conversations in cafes or in a pub or in community centres or, you know, in their local marae or community meeting places, events they go to, sports events? They know where these conversations take place. Could be with the aunties leading it, you know, and the what we call kaiawhina, which is like community health workers. And these are the people that we need to upskill and to get the messages out there in the community because they have a trust in those people. Kia ora, over to you, Nick.
No, thank you. I think I'm going to say actually very similar things. Is almost twofold. The first is education, and the second then is a personalised and holistic approach. Because we have it sort of, you know, again, the approach to frailty varies very much by country to country, culture to culture. And firstly, it's about the recognition of it. You know, for too long, very often we have viewed this as being part of a normal aging process. And we recognize that sometimes some people there are very active, and we think, okay, even though they're 80, we think that, well, they look more like 70, and vice versa. And we, in some ways, accept that. But actually, these are things that we can be targeting and trying to prevent there that can reduce the impact then from illness. So it's recognizing that about healthy aging and the tackling the frailty component of that. But then tackling it is you know, well, it's more than simply medication. It is actually very often then down to things such as diet, activities, physiotherapy. It's truly a multidisciplinary approach. And part of, I think, that multidisciplinary approach is involving, you know, just as everyone's been saying now, for the people that are affected by it, finding out what is acceptable to them, getting their input in shaping it, because we've had it even working with different populations in the UK, is that for some, that, for example, dietary modification will happen to, or is the cultural element of that is possible to a greater or lesser extent depending on which sort of group of individuals you're working with. So it's, again, how we tailor that is going to be very much an individualistic approach. But I think in my kind of closing comment is, you know, that's really where we need to move the field on from stroke in rehab, is this idea of one size fits all doesn't work. And we need to be thinking about how we tailor it according to a range of different things. But obviously, you know, kind of from my perspective as well, is that frailty element there and how it interacts with the whole psychological element, the cultural element there is critical. So it's talking, it's collaborating, just as I think the message has come home from tonight. Sorry, it's tonight in my this morning for my colleagues.
Anna?
Yeah, and I think maybe we should just leave it there. But just something as you were talking, Nick, I have this quick thought on the term frailty. So I'm thinking of my Indigenous population here, and stroke happens at age 45. And when I think frail, I think a little old skinny lady, you know, a little skinny old white lady. And that's probably my own cultural bias, right? Like, so we have to always reflect on that. But that's not really, I don't think that's what frailty necessarily looks like in the Indigenous population. That's perhaps partly what Ivy was talking about. But that's one aspect. And then also, you know, we've encountered this problem with the term rehabilitation, and that carries a stigma. So people think of alcohol withdrawal, you know, like rehabilitation, and also the whole term of rehabilitation. You know, there's a different worldview around who you are after stroke and where you're trying to get to, and whether the term rehabilitation actually applies. And so this is a really interesting concept that I was struck by when I've talked to Indigenous people here in New Zealand, and actually Margaret has mentioned that to me from Canada as well. So I just want to throw that out for consideration, whether the term frailty, which might indicate weakness, you know, like I'm imagining a 45-year-old Maori man, and if I call him frail, I'm not sure he would really appreciate that, and that may be putting words in somebody else's mouth. But it's an interesting thing to reflect on, and that comes back to the language we use, and you know, and of course, I think frailty, we don't usually go even rock up to little old white ladies and say, oh, you're frail, you know, like, but, you know, it's a term we use, but is it a use informed by community? And is there some work to be done perhaps around that? Interesting thought. I would be interested in hearing next.
Yeah, so I completely agree. Nobody likes the term frailty. And when we speak to sort of individuals affected by stroke, they will say, well, I recognize frailty, but I see it in other people. I'm not frail, even though we're there. And so I think it is a shortcoming, although it is a technical term and a sort of clinical term, it is something that also as well has a sort of kind of potentially pejorative approach, or a kind of very much a sort of, you know, kind of exactly as you say, it sums up in somebody's mind when we use that term. There have been, the trouble is, what do you use instead? And there's been quite a lot of discussion within the field. The phrase intrinsic capacity has been used. The trouble is, if you go up to the person on the street, then somebody on the street will recognize frailty. Again, they'll think of it as applying to somebody else, not themselves, but at least they kind of have conceptualize it. If you speak to most people, including people working within the, you know, sort of in healthcare, if you say intrinsic capacity, people will go, what are you talking about? You know, physiological reserve is another one that's been used. I tend to prefer tending to use the phrase things like healthy aging and sort of biological aging, simply because I think people have a reasonable understanding of that. The difficulty is that frailty for now is the technical term. It is then trying to use that, move the technical term then to when we are speaking to other groups. So for example, if I was speaking to a group of individuals affected by stroke or the public, I probably wouldn't use the word frailty very often, if at all. So yes, I completely agree.
I
The
love the
trouble is,
healthy,
what do we
I
call
love
it?
the healthy aging, because also that's a strengths-based, you know, that's focusing on maintaining well-being, which really fits with the Indigenous perspective as well, rather than focusing on the deficit. So preventing frailty. But of course, when you're talking, so maybe when we're talking about frail people, we're talking about people who we want to coming back to Bernadette's point, or something, I think it was Ivy's point, you know, can we cure frailty, you know, like, so returning to well-being, and what does that mean? But of course, then there's other aspects of this. Sorry, I'm probably going, we, you know, think we have
Right.
lots to talk about, but I'll stop.
I
Yes.
think we've had a really engaging discussion, and we're way past time. So thank you to everyone for joining today's very insightful webinar. We've heard perspectives that truly bridge both clinical as well as lived experiences, and some policy relevance points as well. My deepest gratitude to our distinguished guests, speakers, for sharing their expertise and thoughtful reflections. And I would like to thank all the participants as well who have joined us today. With that, I think we can formally close today's session. Thank you once again, and we look forward to connecting in future discussions. Right. Thank you. Bye.